I don't see the chairman, but the chairman, Joe Chirelli should be here too. Okay. So right now, I'd like to have a motion to approve the agenda.
Second.
Discussion. All in favor?
Aye.
Opposed? And a motion to approve the minutes.
And second.
And notation at the top of the minutes is actually March, but it's actually the April 19
Minutes.
minutes.
So all in favor of approving the minutes?
Aye.
With the revision. With the revision.
With the revision. Opposed? Okay. So we'll start with our presentation. Dr. Dorsey.
I'll want me to stand over here? That's good. Now, take my mask down so you guys can hear me.
We might
Well,
have enough for everybody.
Thank you
Send it
for
out.
having
Forgive
us.
us, okay?
I'm going to start the presentation a little bit.
Yeah, we can
Oh, okay. You have one?
So I appreciate the opportunity. We're going through different groups in the community to kind of talk about what's going on in Mercy, explaining why things are changing, why they're changing, kind of talk a little bit about some of the healthcare changes overall that's affecting all of us, not just Mercy. So a little bit about me. I'm John Dorsey. I'm an internist. Came to Rockford in 1984. Worked 3 years at Crusader to pay back a National Health Service Corps scholarship. I grew up on the East Coast, went to med school in DC, and did my training in Pennsylvania. Came here, and after I was done with Crusader, went over to, well, it wasn't even Rockford Health System, that's Rockford Memorial, and went into private practice, internal medicine, and eventually the Rockford Health System. And my practice all the time was on the Rockton campus in the R&B building. Art Rome was my partner for years, and so my whole practice, my whole career was on the west side. Both at Crusader as well as in practice. About 10 years ago, I was asked to go into full-time administration, and I said yes for some reason. That certain days, I really don't know why I said that, but anyway, I said that, and had a different focus early on, more quality outcomes and health disparity issues and things of that sort. And then after Mercy and Rockford Health System joined in 2015, I was asked to step in as the Chief Medical Officer for Mercy in Illinois. And so that's kind of my history here. My wife went to Harlem, grew up in Loves Park, and so she's from the area, and 5 kids together. So Rockford's a good home for us because 2 of our kids are in Madison and 2 of them are in Chicago, the Chicago area. One is Albany that we get about. But Rockford's pretty good in terms of being centrally located. So, so there's been lots of changes at Mercy. I think that goes without having to be stated. And kind of wanted to talk to you about what our initial vision was and how it's had to change. So when we got the approval to build a new hospital on land that was purchased by Rockford Health System in the early 2000s, or I'm sorry, the mid 1995, 1996, that land was purchased by Rockford Health System with the plan to build. When we got permission to build a new hospital, what we envisioned was 2 campuses. We were always one hospital license. We're not licensed as 2 separate hospitals. We're licensed as one hospital, but with 2 campuses. And so the idea is that we were going to have patients on the Rockton campus that needed to be hospitalized, but were not all that sick enough to be in a hospital, but not critically sick. But the more critically ill patients. Those that need complex care were going to be seen on the Riverside campus or transported. And why was that? Well, that's where, we have neurointerventional stroke. That's only on one campus. We have cardiac cath labs on the Riverside campus, et cetera. So the idea was kind of like, well, if you've got pneumonia, let's say, and you're maybe 40 or 45 and otherwise in good health, you could stay on Rockland. But if you're, 70 and maybe have emphysema or something of that sort of pneumonia, likely to get worse, no matter where you entered the system, you would be transported to Riverside. So that was the original concept. And we spent hours as clinicians trying to develop protocols, who should be treated where with ambulance transfers and such. It also went the other way. We had some patients on Riverside who, because we didn't have beds or capacity, were sent over to Rockland. So it was a bi-directional flow. So that was going along okay. But what we were finding is that we weren't always the best at predicting how people were going to do. And some people who we thought weren't going to do too badly did badly. And there were a lot of transfers that were occurring unexpectedly, sometimes at off hours, on weekends, nights, and at times when patients were more critically ill. And that got to really start to unsettle some of our physicians.